Let's study about diabetes insipidus. So, what are the types of diabetes insipidus? In normal language, we can say that diabetes insipidus of two types, that is central diabetes insipidus or nephrogenic diabetes insipidus. In detail, we can divide it into it can be due to deficiency in production of ADH, or it can be due to deficiency in action of ADH. It is nephrogenic diabetes insipidus. So, what are the causes of deficiency of production of ADH? It can be primary deficiency or it can be secondary deficiency. Primary deficiency is also known as neurogenic deficiency or central diabetes insipidus. The causes of primary deficiency may be pituitary or hypothalamic. It occurs due to agenesis or destruction of neurohypophysis. As we know that ADH is secreted from posterior pituitary, also known as neurohypophysis. So it is due to agenesis or destruction of neurohypophysis. Secondary deficiency is due to inhibition of ADH secretion. That is, ADH is formed, but it can't be secreted. There is inhibition in secretion of ADH. It is also known as primary polydipsia. They can be deficient action of ADH, that is known as nephrogenic diabetes insipidus. What are the etiologies? The etiologies first of primary deficiency of ADH is they can be severe head injury due to neoplasm like craniopharyngioma, pituitary adenoma, meningioma, metastatic lymphoma or leukemias. Granulomas like sarcoidosis and histiocytosis, we can see the primary deficiency of ADH. Next is due to infections like chronic meningitis and viral encephalitis. Next is inflammatory like hypophysitis, that is inflammation of hypophysis or pituitary gland. Next is Wegener's granulomatosis. Next is vascular, as we can see in Sheehan syndrome, there is ischemia of the pituitary gland and there is hyposecretion of pituitary hormones. Next is hypoxic encephalopathy. Due to hypoxia, there can be encephalopathy which will lead into ADH less secretion. Genetic defects like autosomal dominant or recessive, they are also having the decreased ADH secretion and it may be idiopathic. So in primary deficiency of ADH, all the causes are related to brain. We can see that severe head injury, that is injury to the brain, they can be neoplasms. So these neoplasms are all the neoplasm of brain. Lymphoma and leukemia are others. Granuloma like sarcoidosis, histiocytosis, infections of meninges, encephalitis, inflammation of like hypophysitis, vascular Sheehan syndrome that includes the pituitary gland. There can be hypoxic encephalopathy. These are the causes of primary deficiency of ADH. Secondary deficiency of ADH is psychogenic polydipsia, dipsogenic polydipsia, or iatrogenic. Psychogenic polydipsia is when the chalo we will lead it later. And next is nephrogenic diabetes insipidus. It is caused by some drugs like lithium, demeclocycline, amphotericin B, aminoglycosides, cisplatin, and rifampicin. Next is metabolic hypercalcemia and hypokalemia that can also result in decreased ADH secretion or its action. Obstructive uropathy, amyloidosis, vascular causes like sickle cell anemia and acute tubular necrosis, genetic and idiopathic. What are the clinical features of diabetic insipidus? There is polyuria, and due to polyuria there will be excessive thirst, polydipsia with predilection of for cold drinks are the cardinal manifestation of diabetes insipidus. So there are three features: polyuria, that the patient will frequently go for urination or micturition; excessive thirst; excessive thirst, and there will be polydipsia, excessive drinking of water. Daily urine output will be more than 50 ml per kg per day, or it may reach as high as 10 to 15 liter per day. In traumatic diabetes insipidus, there is triphasic response, which is there will be initial polyuria, then there will be prolonged antidiuresis, and then final polyuria. What is the diagnosis of diabetes insipidus? We can check the urine. The urine will be clear and there will be low specific gravity. There will be low osmolality, which is usually less than that of the plasma. And however, in primary polydipsia, plasma osmolality may be lower than urinary osmolality. Next is serum sodium is borderline high, indicating water loss, water deprivation test, and MRI of pituitary and hypothalamus. So, what is water deprivation test? It is diagnosis of cranial diabetic insipidus, depends on demonstrating that a rise of plasma osmolality produced induced by withholding fluids is not accompanied by a normal rise in the osmolality or specific gravity of urine, but that when vasopressin is given, such a rise does occur. So, in cranial diabetic insipidus, the rise of plasma osmolality that is induced by withholding fluids is not accompanied by a normal rise in the osmolality or specific gravity of urine. But when we will give vasopressin, there will be a rise. Later test is necessary to show that kidney is capable. That is, when vasopressin given, if there is rise of osmolality, that means that kidney is working properly and it cannot be in nephrogenic diabetes insipidus. And if after given vasopressin there is no rise, that means there is nephrogenic diabetes insipidus. In dipsogenic polydipsia, urinary osmolality rises appropriately during fluid restriction. What is the treatment? We will give desmopressin, which we will give 10 to 20 microgram intranasally once or twice a day. Desmopressin is an analog of vasopressin or ADH. We can give chlorpromide, which enhance the renal responsiveness to vasopressin, and hypoglycemia can be a problem by giving chlorpropamide. Carbamazepine is an alternate drug with similar action, and we can also give thiazide diuretics, which are only effective for nephrogenic diabetes insipidus. Thank you for watching. Like and subscribe, and do let me know in comment section which chapters you want to read. Thank you.